Hi everyone and welcome to the Emergency Physicians ECG course. This is Hesham Ibrahim. I'm one of the emergency medicine consultants in the United Kingdom, and today we're going to discuss case number 8 from our Facebook page. This was a case about a 64-year-old gentleman who presented to ED with an out-of-hospital VF cardiac arrest. He was cardioverted successfully following just one DC shock and one cycle of CPR, and they've managed to get ROSC. There was no history available about the peri-arrest situation, and there was no past history available at that time. He's had an ECG as part of the post-resuscitation care, and this was his ECG. So, as always, I would suggest that you pause the video now, have a proper look at the ECG yourself, now you know the story, and let's see what you think. Okay, I hope you're back now, and yeah, let's talk about this ECG. So let's analyze it together and figure out what we can get out of it. Obviously, the presentation itself was really concerning. It's a post-VF cardiac arrest case. And looking at the ECG, probably what's going to catch our eyes here is going to be this ST elevation in AVR. That is always concerning, especially with a serious presentation like this, especially if it is combined with the ST depression that we can see here in the inferior leads in 2, 3, and AVF, maybe a little bit in V5 and V6 in the lateral leads as well. So that was the first concerning feature. And the second concerning feature is this weird looking ST elevation in V1 and V2. Let's make things bigger. So that is the ST elevation AVR, so for you to see. And this is the very characteristic shape ST elevation in V1 and 2. So I guess many of you now can guess what we're going to talk about. This is going to be a case of Brugada syndrome. So this condition has been named by the three Brugada brothers in 1992. So Josep and his brothers Pedro and Ramon. Three Spanish cardiologists reported this in 1992, and the condition has been named after their name. There are some reports that actually this condition has been described a few years before this in 1988 by a different cardiologist, but it's now well known worldwide as Brugada syndrome. So it is the second commonest cause of death after trauma in Southeast Asia in individuals below the age of 40 years old. So it is far more common than what some of us might think. The inheritance of it is autosomal dominant, and the male to female ratio is 8:1, so it's kind of a boy's disease, and the mean age of sudden death is 40 years old. The usual presentation is going to be young adult male, less than 40 years old, previously healthy, no previous medical problems, suffers from a sudden cardiac death while asleep, with a positive family history of the same condition. How it happens is important to understand, so let's talk a bit about the pathogenesis. It's a genetic defect in the cardiac cell membrane, and it's a sodium channelopathy, so it's a problem with the sodium channels that results in abnormal repolarization of the myocardium. Let's try to make this a bit clearer. So, looking at this diagram here, so at the upper bit, so this is our cell membrane. These are the sodium channels that we can see in here. Sodium is outside the cell, and what happens when you get stimulation is you get the sodium to go into the cell, and then the gate will close, and this will result in the normal action potential that we can see here. While with Brugada syndrome, the problem is you get a premature closure of the sodium channels. So actually you do not get enough sodium into the cell. So the action potential doesn't happen in the normal way. So what happens is, because of this less amount of sodium that they go through the gates because of the premature closure, you get this gradients, you get this difference between the normal action potential and the action potential of Brugada patients. And because of this results in this characteristic shape that we see in the ECG of those patients. So this is an interesting part of Brugada syndrome patients. There are factors that will increase the ECG changes. The ECG changes are not fixed changes. First thing is fever. So interestingly, they found that some forms of this gene, the SCN5A gene that results in Brugada syndrome if it's mutated, that change, that Brugada syndrome changes, the channelopathy, happens only at high temperature. So to my knowledge, this is probably the only patient who can get VF cardiac arrest with any febrile illness. The other thing that might change the ECG changes or aggravate the ECG changes is, as you would expect, drugs, in particular sodium channel blockers. We've got already a problem with the sodium channels that they don't allow enough sodium to go in. So if you add on top sodium channel blockers, that will make things worse, in addition to some other drugs. And lastly, sleep with increased vagal tone. It was found that it provoke and make the ECG changes of Brugada worse, especially from midnight to 6 o'clock in the morning for some reasons. Are there any types of Brugada syndrome? Yeah, it is not just one type. There are actually 3 types of Brugada syndrome. Type A is that one with this characteristic shape of ST elevation in V2 that looks like a shark fin. And that is the famous one, and this is the most important one that we need to be aware of. Type 2 has got an ST elevation in V2 that is saddle shape. Type 3 is very similar to type 2, but the elevation in V2 is less. And having discussions with our cardiology colleagues, some of them believe that actually type 3 doesn't really exist. So I guess type 1 is the must-know one. Type 2 is important to know. Type 3 is, I'm not really sure. So what do we do when we get a case of suspected Brugada? In terms of investigations, obviously ECG is the first thing we do. So changes can come and go. That is an important thing to know. So having a normal ECG doesn't mean that this is not a Brugada case. And what you will see in the ECG is that pseudo-right bundle picture with an ST elevation in V1 and V2, sometimes up to V3, that is followed by a negative T wave that looks like a shark fin or the curved type of ST elevation. So electrophysiological studies, they do programmed electrical stimulation that can reveal it. And then the Ajmaline test or flecainide test. Basically, these are strong, potent sodium channel blockers that they give to these patients in a controlled environment to unmask arrhythmias and reveal the Brugada. And lastly, obviously genetic studies is always there to confirm the diagnosis. How do we treat this condition? Well, it depends. If the patient is symptomatic with Brugada ECG pattern, then they get an ICD. If the patient is asymptomatic with Brugada ECG pattern, then they get some sort of a provocation test. So either electrophysiological study or Ajmaline test, and if there is an inducible arrhythmia, then they get an ICD. If there is no inducible arrhythmias, then they just follow them up. So back to our case that we've started this discussion with. It was the 64-year-old gentleman who presented with a VF cardiac arrest. We've managed to get ROSC, no previous history. That was the ECG that you've seen. So this was the presenting ECG. So what happens in this case was, because this patient presented to a hospital without PCI facility, so the patient is being transferred to a different hospital for PCI. That's because of the concern about the ST elevation in AVR, plus an ST elevation in V1 and V2, plus the fact that this is a post-VF cardiac arrest. So the patient was transferred there, had PCI that showed clean coronaries, and then he's had an ICD. Looking backwards at his notes in our hospital, we found this old ECG that was done 2 to 3 years, I think, before the presentation with VF arrest. So let's make things a bit bigger. That is what we found 3 years before this VF cardiac arrest. And we found in the record that this patient has had a positive Ajmaline test, and for some reason he hasn't had an ICD fitted, but thankfully he's had it after the successful resuscitation of his cardiac arrest. So let's summarize what we've talked about, and I'd like to have some music in the background here because I hear this at the back of my head each time I talk about Brugada or I see Brugada. Don't know if you can hear it, but yeah. So Brugada syndrome is not that uncommon. Always consider it with any syncope or unexplained cardiac arrest. It is caused by premature closure of sodium channels. It's getting serious now. There are 3 types of Brugada syndrome: type 1, type 2, type 3, and type 1 is the curved type 1, the important one. Never ever let the shark bite you. Refer all suspected Brugada ECGs to an EPS cardiologist. That's enough. And positive cases are treated with an ICD. So this is it regarding this case. I hope you find this useful, and I will talk to you very soon. Bye for now.